I will call the meeting to order. Welcome, everybody. We have one set of minutes for approval. Do I hear any changes or a motion?
Move to approve minutes.
Second.
All those in favor say aye.
Aye.
Aye, motion passes. All right, next up, we have the draft environmental impact statement and updated draft implementation plan for the National Flood Insurance Program. Welcome, community development, and thank you everyone else for letting us hijack some of the meeting for this.
Yes, thanks to our health colleagues for letting us tag on this. This is a little bit time critical one. That's why we had to do this. But generally speaking, Toby has outlined things for, we had the presentation a few weeks back. So today she sent a memo out, I think, or an email yesterday, kind of the three things that we would ask that you look at today. And hopefully we can get through this in not 60 minutes, but quite a bit less. And at this point, I'm going to defer to Toby because I'm just here so I can get fined. Oh.
Well, again, thank you for letting us occupy some space during this meeting. Real quickly before I start, we've got Jesse Ott from Natural Areas Parks and Events online, and we also have, I believe, I can't see the screen because I can't see that far away, but I believe Gallup Katra and John Graves, both from FEMA, are online as well.
I see Galib.
Yeah. So John may be joining us later. Gallup is the point of contact for the draft environmental impact statement that the public comments would be responding to. John Graves is the branch chief for FEMA Region 10. They've both gotten permission to attend and answer questions if you have questions of them. So, and then Laurel Beyer was not able to attend today because she had a meeting conflict, but she did submit a memo just kind of outlining the impacts of the proposed changes to public works, standard public works type projects. So today's meeting, the goal is to choose an alternative that the county wishes to support. The options are: alternative one is take no action, leave the National Flood Insurance Program the way it is, and do not implement any of the suggested changes to flood storage, water quality, and vegetation requirements. Alternative two would be implement the no net loss standards. So new regulations that would address those three key habitat functions, with the exception that projects, large-scale projects that are obtaining a state or federal permit, such as a joint permit from Corps of Engineers and DEQ and Department of Environmental Quality and Department of State Lands, or other types of permits like that, don't need to meet the proposed requirements, but all of the rest of the standard development. So people wanting to put a house on their property or build a business or something like that, if it's in the floodplain, they would all need to comply with the proposed changes to the floodplain requirements. And alternative three is that everybody who's developing in the floodplain needs to comply with those three, the changes to protect those three habitat functions. And then, so choosing an alternative to support, and then also kind of finalizing the reasons for why that choice is chosen. After today, staff will finalize the letter, provide it back for review and approval, and then bring it back. We'll submit it on October 6th. That's the deadline, or before, for submitting public comment on the draft environmental impact statement, and then bring it back to the board on October 7th for ratification. So I've added a letter that we received from CFM advocates, that the sample comment letter very strongly supporting alternative one. It's got a lot of good information in there regarding reasons to support that, information about alternatives to and potential impacts. The memorandum from Laurel has very specific details on how alternative 3 would impact proposed, how having to meet those the proposed changes to protect the habitat functions would impact public works type projects. While I was at the Northwest Regional Floodplain Management Association conference last week, I had an opportunity to speak with a lot of different people from various agencies and jurisdictions. And from a, just kind of a local floodplain management staff level viewpoint, it seems like both in conversations last week and over the course of this project, it seems like most jurisdictions are either saying alternative 1, or we don't think alternative 1 is an option, and so we're going to support the least worst option between alternative 2 and 3. But alternative 1 still is an option. Most agencies that are not specifically local government, it seems like are taking the same route as CFM advocates and really strongly supporting alternative 1. I think the group that's of the local government groups that are, or agencies that are leaning towards alternative 1 or 2, I think it's more out of a feeling that alternative 1 won't be chosen. And so which way do you steer something that you're not in agreement with, but trying to come up with the best alternative? So I guess at this point, Jesse, do you have any thoughts on that you'd like to share from your department's perspective on how these might impact?
I think a lot of what we're wrestling with is with some of the alternatives, without a mitigation strategy, on sites that might be hard to mitigate for the work that they're doing because they're too small. So I think from us, we're not doing a lot of building, and what our kind of role would be in is habitat restoration when it comes to this type of project. Yeah, I think a lot, I've been with Toby and Laurel since the beginning of the process, and kind of feel the same way about alternatives 1 and 2 kind of being more of an option. I think one of the concerns that we have just in general with working with a lot of our consultants is the overall cost of some of the measures to implement, and we worry that can slow or stop projects altogether. But yeah, it's been really interesting kind of going through this, but feel really similar to Laurel's comments.
Thank you, Jesse. And so I think one of the things that I also wanted to bring up as well was participation in the National Flood Insurance Program is a voluntary choice by local jurisdictions. Years ago, when it was set up, jurisdictions chose to either participate and have the option of receiving federal disaster assistance if there's a disaster declaration. If your community is participating in the National Flood Insurance Program, which one county does, then there are minimum requirements that need to be met. My best guess is that most jurisdictions no longer, whoever's in place in each jurisdiction at this was not part of that initial decision. And that most jurisdictions don't feel like it would be very feasible to stop participating in the National Flood Insurance Program. But in order to continue, if alternative 2 or 3 is chosen, we'd need to enforce those proposed changes. there's a high level of concern about adding habitat protection requirements to a program that was set up to protect people and structures, and help reduce risk, not necessarily to encourage development in the floodplain, but if you're developing in the floodplain, to do so in a way that is going to minimize your risk. So that when there is a flood, your structure doesn't get as damaged, you're able to return to your normal daily activities as quickly as possible. And there's another sentiment in there is that this program is not the right place to add habitat protection requirements, that those protection requirements should continue to be addressed where they currently are addressed in other federal agencies. Not that they're not important, not that people don't want to protect habitat or see, fish thrive, just that this particular program may not be the best place for those regulations to be implemented.
Sure. So it sounds like there were good intentions, but this maybe is just not the appropriate vehicle for that.
Yeah.
Okay.
Which I think is why we see CFM and others saying status quo as in leave it option one.
So talk to me about that a little more. I've seen a couple things that say that it's not feasible, but it might be feasible. To explain that a little bit to choose option one.
So typically with an environmental impact statement, it's my understanding that alternative one, which is your no action option, right, is developed as a baseline. This is what we're doing, and it's used as a comparison for other alternatives. But it's not that it's not typically, the way I understand it, I'm not familiar with these. I don't work with these a lot, but is that alternative one is just identification of where a system or a program or a project is at, and you're wanting to make a change, so people don't choose alternative one. Prior to a couple weeks ago, I felt like alternative one was not on the table. But it sounds like it may be just as much on the table as alternatives 2 and 3. The data used for the, as mentioned in the CFM advocates letter, the data used for the development of these requirements is kind of outdated. It's a project that's been going on for a very long time. The feasibility of implementing alternative one is, I think FEMA is going to get sued whatever option they choose. So the question is who's going to do the suing.
And you mentioned like the lesser of two evils sort of thing between 2 and 3. And I guess, I just don't feel good about choosing, if both options aren't great, I don't feel good about that. And I almost would rather say, hey, this isn't right. We choose neither. Please reconsider.
Mhm.
But that's just, you're our floodplain expert. So, do you have?
I think one thing to think is that if we go with the status quo, at the end of the day, FEMA's going to come up with something. This is a draft environmental impact statement. They are looking for our comments.
Okay.
And so they'll analyze all that. And I suppose at some point they'll make a decision and we'll react accordingly. I just know for us, especially if we go to Public Works, 2 and 3 are not our friends.
Okay. I'm inclined to say, this, for all the reasons that we have listed in here, we don't like either of these options. Please reconsider. And again, I don't know what the feasibility is, but you also mentioned they're probably going to get sued. Sounds like it's going to be a lengthy process anyway.
It very well could be. And you asked my opinion on it. For a long time, I've felt like we should just kind of sit and wait and watch and see what's going on. Had you asked me when I put together the draft letter, I would have said I was having a tough time between 2 and 3, because 2 allows larger projects not to have to add on extra requirements, but those larger projects are also have the potential for a lot more impact, right? And it's just kind of a for now thing, because it could be that in the future, the Endangered Species Act compliance and reviews that are currently being done through other agencies could incorporate these. But in the time since then, and the last couple of weeks, today I'd say I would recommend alternative one.
Other comments from commissioners?
Yeah, I appreciate the having another chance to go over what our options really are, and it seems like things have opened up since our last discussion, and that option one is on the table. I mean, I feel like I've been an environmentalist my whole life, and so appreciate trying to take care of the earth, but this, and I really appreciate CFM's letter. It's nice and clear that option one is a viable option, and conflating flood insurance program with endangered species may be well-intentioned, but makes things really complicated. And it's not like we don't have other ways of protecting endangered species. It's a little bit different look, but the Oregon legislature 2 sessions ago, I think, passed the private forest accord, which puts significant new restrictions on what woodland owners can do, and increasing the riparian buffers. And I'm not super familiar with it, but I know it made significant changes in what could go on in the woods, and a lot of it was to protect the watersheds and the fish that are in, or other species that are in the streams. And this just seems like trying to mesh 2 things that don't fit together very well. And appreciate the comments from Jesse and Laurel in Public Works that this could have at times a significant impact on projects that are already difficult to get through all the hoops. So I'm leaning strongly towards the first option, and appreciate the intent, but I think the flood insurance program is just the wrong vehicle. And I can, as we have the flood insurance through FEMA, so I'm familiar with how they operate, at least on a individual level view.
So I spoke with you recently, and I appreciate all the stuff that you said then and repeated today. Excuse me, but there's one bit that I also want to clarify again. When we spoke earlier, you said that a large section of South Corvallis between Highway 99 and the Willamette River would be in the floodplain here that we're talking about, right? And that's where a lot of economic development and development is going in Corvallis with their South Corvallis urban plan. And you also mentioned a large swath of Philomath would be affected by this, correct? So also from that point of view, I agree with my colleagues here about supporting alternative one. I think that between the area of our county that this would cover. Area that's currently growing, and yeah, growth should be thoughtful when it's in a floodplain. I completely understand that. You know, it's a part of our communities that are growing. I agree that this is not the right, we keep saying vehicle, I'll say vehicle for this program. So between those things, and just the impact it would have financially on our staff and on our communities, I'm also in support of alternative one, which I guess my question is, what do you want from us today about it?
So first of all, there was just choosing an alternative to support. Secondly, identifying some reasons, you know, if you want me to just pull what you feel, if there are certain key points in the CFM letter that you feel need to be included, if there are points in the draft letter that you'd like emphasized, if there's, you know, other points or ways that, you know, you would like something phrased to support the alternative that you're choosing, which sounds like one, then just ideas on that. For a little bit of context in terms of how large of an effect this has on Benton County. So we have about 434,000 acres of land in all of Benton County. That's unincorporated and incorporated cities. About 59,000 acres of that is mapped as floodplains. So that's about 14% of Benton County. The same is true just in terms of percentage wise for the unincorporated portion of Benton County. It's about 14%, which is like 57,000 acres. The incorporated cities, so Corvallis, Albany, Monroe, the portion of Albany that's in Benton County, Monroe, Adair Village, and Adair Village.
So you said
Yeah,
Paloma?
Philomath, yeah, okay, thank you. I was like,
I also lost track of which ones you said.
Yeah. They're at about 1,900 acres, so, and still ranging at about 14% of their communities.
Okay.
So, you know, it's a decent chunk of land. For Benton County, the majority of our flood hazard area is zoned for farm use. That's about 93% or something, well, not 93%, it's lower than that, but farm and forest use combined, it's about 51,700 acres. So, and we've got about just over 3,000 structures located in the floodplain for unincorporated Benton County. So that doesn't include any of the incorporated cities. And about 700 of those are likely dwellings. So if that helps give some context for how many.
So Toby could, the draft letter was sent. Have the draft letter kind of memorialized by what date?
Well, so.
For you to have it ready.
Yeah, so ideally by Friday at the latest.
So would that give the board then time to send comments to you and then you could finalize the letters, how it?
Well, I think so. First, I want to entertain a motion to support one of the options.
I move the Benton County Board of Commissioners support alternative one.
Second.
All those in favor say aye.
Aye.
Aye, motion passes unanimously. Okay.
Can I add one more thing? I just wanted to put in a reminder that Golub is online if you guys wanted to ask him anything.
Do any commissioners have questions for our online folks?
Thanks for being here, Don.
Yes, thank you. Okay, so some of the reasons I think would be good to include, and commissioners tell me if you agree or disagree, is, I mean, first, I think we should state, we definitely want to protect the environment. We want to protect endangered species. But that this is not the correct or the most appropriate method of doing that, not the correct vehicles, we've been saying. And there are a lot of unintended consequences. Some of it feels a little bit arbitrary to me because, I mean, every floodplain, every situation is different. And this is like 3-to-1 ratio And, you must now plant 47 trees. Well, in Laurel's example, it's like, there's not room for 47 trees. Like, it's not always like, it's not feasible. You know what I mean? It just seems more arbitrary and less feasible in real life. Other comments?
Just in the letter note how this would affect our municipalities. And, you just cited a lot of good numbers, and I think that's just would be important to include. It looks like there's a suggested place to include that in the CFM letter. So I think adding that in there would be important. And I agree with Commissioner Wise's statement about emphasizing that we're not opposed to protections for endangered species. It's just, this isn't doing it.
Any other comments?
I really appreciate the CFM letter. It's nice and clear. I guess I would use that as our basic response with specific comments that refer to Benton County in our situation. The number of acres that are number of acres percent of our land that's would be impacted. Toby, you were quoting a percent of land that was in the floodplain. I know there's another process going on redefining who's in the floodplains. Are your numbers with the old 2010 or whenever it was mapping, or have we graduated to the new more accurate designation?
Those are based on the current maps in effect, not the draft maps. So the numbers may go down a little bit. I don't expect that they'll change significantly, just based on the sheer quantity of land that we have in the flood hazard zone. It might go down a percentage or two,
Okay.
but I don't think it'll change a lot. One question that would you like me to continue to use the same format that I have for the draft letter? Would you like me to revamp it? Are there parts that you want removed?
Feelings on that? It depends. Is it easier to change what you already have, or is it easier to kind of start over?
Either way, I will do whatever you.
I feel bad because I also don't have strong opinions.
Whatever is easiest for you, I would say.
Okay.
It's fine. Yeah.
Okay, I just wanted to make sure if there's stuff in there that you felt like, yeah, we don't really need to include this or something,
Okay.
I'm happy to scrap it.
Yeah, and I will say also, I appreciate the portion about the large scale projects qualifying for the alternative compliance option will be exempt from mitigating for the key habitat functions. It's like, again, that's not equitable if it doesn't apply to every project. So I think that's good to leave in there, but there's not necessarily anything I would take out. I would maybe add in some of Laurel's examples.
Would you like me, so she mentioned to me separately that she's okay with that memo getting submitted. Would you like me to include that as an attachment?
Sure. That'd be great.
Okay.
Yeah.
Thank you.
Do you need anything else from us?
So I think first motion was to prepare the public comment letter, including discussions and supporting alternative one. Second motion was to submit the final public comment letter signed by Board of Commissioners to FEMA on or before October 6th and direct.
Need a second motion.
Okay.
Well, I can make this second motion because my first motion wasn't that, but I move to direct staff to submit the final public comment letter signed by the Board of Commissioners to FEMA on or before October 6, 2025, and to direct staff to present the final public comment letter at the Board of Commissioners meeting on October 7th, 2025 for ratification.
Second.
All those in favor say aye.
Aye.
Aye, motion passes. All right.
And thanks to our health.
Yes, thank you.
You have
Welcome
fun.
anytime. Come and hang out.
Well, thank you. This done in 30 minutes.
No, long-winded.
Okay.
It was your meeting.
Oh, okay. Just have things to say. Okay, so next on the agenda, Health Resources and Services Administration Operational Site Visit Report.
All right, I emailed you guys, but it's okay, I can meet from here. I joined the meeting. Okay.
Shuffle.
Right, shuffle. Well, the good news is we had our operational site visit and it's over. We did, we survived, which is fantastic.
Every 3 years.
And well,
Now
actually, it's
four.
now 4, yeah, it was a new reduction of administrative burden.
Great.
We appreciate it. Oh, fantastic. Oh, should I grab a clicker?
I have got it.
Thank you very much.
Okay.
You just like point it in the air and then it does something. Oh, it's working. Sorry, I wasn't paying attention. The slides changed. My bad. I'm sorry. All right, here we go. So essentially, the HRSA operational site visit is an open book test. We get to submit all of our data ahead of time. So, which is fantastic. It's always great when teachers let you write down everything on a 3x5 index card. That's kind of what happens. And so, it was a good visit. It was September 9th through the 11th. We had 4 representatives. Eric was from HRSA, from the Bureau of Primary Healthcare, and then the 3 contracted consultants for fiscal, clinical, and governance consultants. There are 21 compliance elements for the Health Center program, and they review 20 of them. The 21st one is the FTCA compliance component, which is separate, and they can, we have to attest for that every year or apply for to be a deemed entity, and then they reserve the right to come at any time to do their own on-site audit. So I don't know where the wood is, but that one is not open book, so. And then just kind of thinking, we did some education for the Health Center Board, but kind of trying to help folks understand the Health Center governance program. So we've got HRSA, who has been charged by Health and Human Services and HHS to oversee our programs. Then we have federal, state, and local laws that we have to comply with. Then we have board roles, which health centers have to be at least 51% consumer board members, which we are over 51%, I think 60-something percent. Look at Patricia, she's like, yeah. And then, of course, then we have to have our own policies and procedures that help us rely or govern well. So the OSV process, for us began about a year ago. We had our leadership team all come together, and they provide us with a lot of tools for preparation and to make sure that what we're doing what we say we do, so that our policies and procedures align with HRSA's requirements, and then that we are in practice doing what our policies say. So we did spend quite a bit of time preparing for that. Then all of those documents get uploaded. And then there's the 2 days of interviews, and then the exit conference. Then the last component, which we'll kind of visit here about, is the compliance resolution opportunity, which is where we have the opportunity for corrections, which we will tell you about what our corrections were. There are 97 elements that are assessed during the operational site visit, and we had 5 elements that were that needed to be addressed. So, and we'll go into each one of them here briefly, I think, or no? Okay,
Yep.
sorry, she updated the slides from our board meeting. I don't want, Christine was gone for 2 weeks and I had to do all my own PowerPoints and that was stressful. So, I told her that last night. So the first one had to do with just updating our contract with Samaritan Health Services. They, our previous contract said ancillary services and specialty referral services. And for anyone that works in healthcare, ancillary is everything. And so if you Google it, that's what it is. It's all the supportive services. So radiology, mammography, laboratory testing, physical therapy, speech therapy, occupational therapy, all the therapies. Anyhow, they wanted a specific amendment that called out 3 changes that happened in the scope of services manual when it was republished in March, which was to just state specifically that they would provide mammograms, that they would provide gynecologic ultrasound, and that they would provide plain film x-rays. So they did that, which actually that's quite a feat to get a contract turned around in a week with Samaritan Health Services. Just want to put that out there.
So that's really a success.
We know all the right people now and their phone numbers. And then the second finding was around the sliding fee scale, that we hadn't appropriately defined what a family, how we define family size. So, and so Debbie Sessions, who has been our interim health finance officer, spent some time with our finance folks from HRSA, the representatives, and updated this language. The CHC board passed this because this is their policy. And so this one has been corrected. There were 2 related to quality assurance and quality improvement, particularly around the peer review process. So in a healthcare setting, it's really important that clinicians have peers review the work that they're doing to make sure that what they're doing is appropriate and meets standard of care and best practices. And so our QA policy, which the CHC Board of Directors approves, stated that we were doing medical quarterly, we were doing dental regularly, and we were doing behavioral health twice a year. And the statute says quarterly for all of those things. So we just had to insert all clinical services will be evaluated quarterly through peer review. And then the second thing that we found was that it had been some time, probably pre-pandemic, some of these quality things kind of fell away during the pandemic and all the leadership change that happened in the health department and health services department, but peer review hadn't been done in quite some time. So we have implemented in behavioral health. So we have implemented that update and change, and they were so responsive. We're super grateful for Damien's leadership and Ashley Talamantes and Ricky Garcia and Dr. Nebaker, who all acted really quickly, and they got those peer reviews done in a week. So that one was also corrected, and we're in good shape moving forward. And then there was one other finding that was actually a finding the year or the last operational site visit we had, which was what we do if we need to waive fees for an individual. And we have this great form. That's an old form. I mean, it's the old letterhead, so please forgive me. But that says, you know, we will waive fees for patients and clients if it would cause them physical or mental stress. And so the HRSA representative said that was the cutest policy he'd ever seen. But it doesn't meet the standard.
What medical bill doesn't?
Exactly, so that's why we thought, we're like, I feel like everything like it causes me mental distress. But what they really just wanted was for us to talk specifically about, in the instances of, like kind of catastrophic situations, personal, emergencies like a flood or a house fire or a job loss, or let's say, a medical diagnosis like cancer or something like that. So the policy was updated, and actually this afternoon we have a meeting to, update all of our processes so that way our staff know how to implement this. So we are very grateful and happy. They did a great job of reminding us that we don't do a great job of celebrating the work that we do on a day-to-day basis, and remembering that, you know, that is why we're here. So when we do that well, we should be proud of the work that we're doing. You know, since we're really grateful, all of the leadership in the health centers really spent a lot of time over the last year. We had teams that were working on these different projects, and team leads, a lot of people participated that haven't previously participated. So the depth of our bench is a lot deeper. So if there is, you know, heaven forbid, more leadership transition, we have a lot more people that know how to go through this process and what to do and how to lead through it. So that's a great opportunity. We're really grateful for our partners in the health department who really have been super supportive and showed up for us. April and Damien and Sarah came at the, I know Sarah was coming. Sarah came at the last minute. We were like, please come and help talk to us about community health assessment, and they were just super impressed with the relationship. They said that this was the healthiest public entity health center that they had been to. And, you know, they see a lot of these places, so we should all be really proud of that. They were super impressed with the co-applicant agreement. They said that that was one of the best ones they had ever seen. So that I know was a lot of work, and took a lot of time to get that done. So we are super grateful and proud of all that work. So kind of just lastly want to leave with, we have submitted all of our corrections, and now we're in that 45-day waiting period for the final report. Depending on what happens by midnight tonight, that could be longer than 45 days. We don't know. But just a reminder, this is just a little teaser for us, just to remember, we did a great job delivering services. We proved that we are following the rules and our policies and procedure, but grant compliance also lives with Health and Human Services and the Office of Management and Budget. So we have other kind of entities that we are also responsible to for the fiscal grants that we have. So just wanna doing a great job. Yes, we are, but we continue to have to work on compliance for all the other components. So that's our update.
Well,
Oh, thank you guys. So this is, yes, this is our thank you slide to you all.
you're welcome.
Yes.
Wow, that's great. And it's just amazing to think of 3-4 years ago and just the enormous amount, the distance, everything that's been covered and changed in that co-applicant agreement. Like, it's just been an extraordinary amount of work, and you guys are awesome. Good job.
Thank you.
They were extremely complimentary. They were very impressed. So I went to the
Board session.
yeah, I went to the lunch where they interviewed the board, and they had more questions for me than I expected. I thought I was just kind of be there to support, but they drilled into me. And then I attended the exit interview as well, and they had an incredibly long list of nice things to say, great things to say about not just the functionality of the health centers, but the people who work there too. So, you know, you guys did an amazing job. And it's great to see that these 5 findings were able to be fixed within like a week. That's incredible. I told Zan and she was overjoyed. Yeah, so like,
She should be proud.
yeah. So just, yeah, they were very complimentary, and they also were very complimentary, just like I said, about how they interacted with staff. They were very grateful for the thank you notes that they wrote, and like little goodie bags with all the information. Yeah, it really made a difference, and they were impressed by the relationships between the health department and CHC and the board, like those three organizations. So they were just, yeah, it was great, and I'm very, very pleased. So, well done.
Yeah, similar comments. You've come a long ways in several years to get various houses in order, including fiscal. And I appreciate the amount of effort it's taken to get to this point, and to have a third party come in and take a look and kind of reaffirm what we already knew, that you were doing a good job, is helpful. And I would tag along with their comments about celebrating our successes, and I see we have our PIO there at the end of the table, and it's a general comment where not just you folks, but the county in general, pretty good, real good at doing the job, not so good at getting the word out, what a good job we're doing, or even the challenges that we're dealing with, or whatever the context is. And so I'm glad they brought that up.
Yep.
Because that's really important to, it's great that we know things are going pretty well and better than they were, making progress, but to let the wider community know, I think is also important. That just to kind of repeat, we're heads down and doing a good job and meeting deadlines and working with the budget, but celebrating internally, I think, is important. Kind of let staff know that we appreciate the hard work, and then try to get that word out to our community. Good job.
Thank you.
And it's nice to be reaffirmed what we already knew, that
Yep.
we're doing a good job.
Yeah.
And
Tests are good though, right? If you're competitive anyway. It was an A.
and I guess the other thought is connecting this information with the funding folks, and that there's, oh, you're doing a good job, here's the money, kind of.
Yes, absolutely. We'll talk a little bit more about that in our next presentation here in a little bit.
Good.
Yeah.
Very good. Well, and I think competition is a good thing. It can make everyone work a little harder.
Yes, yeah.
Get you focused.
Yes, for sure.
I don't know that I need to compete, but I appreciate focus.
But we did like hearing that we were the best public
course.
entities.
Yeah, I like hearing that too.
They've been to at least one in Oregon. So,
Yeah.
Did you get that, Ann?
yeah, that was their direct quote.
I've already reached out to Christine.
Oh,
We
good.
start talking about this. Pretty soon.
I was pretty sure you were on it.
Okay. Any other comments on this agenda item? Nope. Okay. I'm actually going to call for just a quick 5-minute break before we power through the rest of the meeting. So let's come back at 9:55. all back. So let's get going with the next agenda item, our Public Health Accreditation Board update.
I'll kick this off and hand it off to Sarah and perhaps Amanda. So when you think about the last site visit that was just discussed with the CHCs, this is quite a different process that we undertake in the health department. First of all, it's totally voluntary. So all the work and effort and, dare I say, pain that we put ourselves through for health department accreditation is a strategic choice, really. We choose to not only do this voluntarily and without funding, but we pay to undertake this process. And really, some of the greatest benefits of health department accreditation or public health accreditation are, first of all, it's a really structured way by which we can document and demonstrate the work that we're doing as compared to best practices. And it really, in our case, it forces us and really centers around embedding quality improvement into the day-to-day culture of public health work. As you know, was noted earlier, we do a lot of doing, and we're always improving our processes, but really formalizing that process has great benefit. And so the health department was first accredited in 2017. And usually it's a 5-year process. Enter COVID-19 pandemic. And this is our cycle for reaccreditation now. And we just had our site visit on the 24th, I think, of September. We have a dedicated staff member, Amanda Garcia. I don't know if you've met Amanda before. She has been working for 2 years now. 3 years. 3 years. I'm so sorry, Amanda. Not only on live, we are having so much fun. Yes, many standards and measures to demonstrate a lot of bringing teams back together as work was necessarily changed and adjusted throughout the pandemic, and lots of plan writing, process writing, finding these examples of that great work to demonstrate what we do. So Sarah will take it from here, as it is a public health accreditation, although it accredits the entire health department.
Thank you. So as April mentioned, we engaged in the voluntary reaccreditation process through the Public Health Accreditation Board. Our site visit was on the 24th. It was virtual and just a half day, which is a short and sweet site visit. We had 2 independent reviewers that participated in one liaison with FAB, the accreditation board. And I felt like it went very well due to the amazing work that our public health team does and the wonderful job that Amanda did in documenting that work and ensuring that that was submitted. Overall, the feedback was that we were successful in meeting the standards and measures of the 12 different domains. The reviewers noted a strong commitment to accreditation and quality improvement, and shared that staff feel supported and satisfied. They recognize that the health department values and supports the physical and mental health of our staff, and that we're dedicated to reaching the community. They also highlighted that we benefit from a supportive governing entity. That's our Board of Commissioners. So thank you so much for all of the work that you do to support our public health department, our overall health department, and to advocate for us when we ask for your help. And thank you to Commissioner Weiss and Commissioner Shepherd for participating in the governing entity session. It was pretty short and sweet, 15 minutes for each of you. And they asked just a couple of questions around how we partner with the Board of Commissioners and how we communicate with you. They really want to see that we're in partnership and that we're keeping each other informed and updated. They gave us three strengths that this is not verbatim. We will get our official report at a later time. But overall, they shared that we prioritize engaging with the community to identify issues and seek solutions collaboratively, and that we make data accessible, with emphasis on gathering local information, promoting evidence-based practices, and responding to local needs, and including those in our community that may experience health disparities or don't normally have a voice at the table. They also highlighted strong staff and leadership partnership, which contribute to program efficiency, help us reach specific populations, and extend our impact in addressing emerging issues and emergency situations. They also noted our robust practices to address social determinants of health, both in staff support and in departmental planning and processes. They also highlighted our health communications team, so the targeted communications and direct engagement ensure programs and services reach the populations most affected. They also highlighted three opportunities for us. One is completion of our strategic plan, which has been on our list of things to do for us for several years. And they would love to see that as a kind of a living document that we update as emergent issues arise. And using, encourage us to use a consistent format to track progress. And then, of course, support alignment with some of our other plans that we have in place. And I think they're right on. So far, I think they're right on with, with our strengths and our opportunities. They also encouraged us to continue to work on strengthening our quality improvement, which is something that is just, it's always ongoing. Continuous quality improvement is something that we always strive for. And so that felt like an easy opportunity for us to continue to move forward with. We're also piloting a new performance management system. And so that was another opportunity as that rolls out, to ensure that all staff have opportunities to learn how to track and use data to connect their efforts to the overarching goals, evaluation strategies, and shared priorities. So the final report will be available in about a month. Yeah, we're on docket for February 13th.
Yeah, so we'll have that available to share. So overall, the next steps, we had until, was it last Friday?
It was Friday, yeah.
Oh my gosh, because this happened last week. We had until this last Friday, so we just had 48 hours to submit 3 reopened measures, which is tiny. And so one of them was to resubmit our updated 24/7 emergency on-call policy, because we are required to have on-call duty at all times in case we have an immediately reportable communicable disease or a public health or environmental health emergency that needs to be reported and responded to. And we have that, so that was easy to submit. And then there were 2 other measures that they couldn't open. They just couldn't open it because the file was too big. And so Amanda took care of working with Sam to compress those files and get it resubmitted. So overall, easy peasy. I think it was October 24th that the report should come, and then the site visitors
just kind of compile all the information and then they give it to the FAB accreditation committee. So we're on the agenda for November 13th. They will determine what our reaccreditation status is. And so there are three possible outcomes. One is that we're reaccredited. Hooray. Two is that we're reaccredited with additional reporting. And three is that we are reaccredited, but with an ACAR. An ACAR is Accreditation Committee Additional Requirement Status. So that would give us a year, up to a year, to provide additional documentation. We think that we might have an ACAR status.
Potentially, the strategic plan is a foundational capability, so without that big plan, the likelihood is that we would receive an ACAR, but all of these, I think is worth noting that we'll be reaccredited no matter what. We maintain reaccredited status. So for any outside, entities that are looking to see if we're an accredited health department, we will be, and we'll maintain that throughout this entire process. So
Yeah.
I'm still kind of hoping we'll be reaccredited with extra.
Regardless, it was really wonderful to see all of the work presented in one place. And as you mentioned, Commissioner Malone, we don't often sort of take the time to step back and celebrate and appreciate all of the good work that we do together with the community. So I know that in the health department director session, I found myself getting quite emotional and had to look to April to finish my sentences. So, so much gratitude for our staff and the support we receive. So thank you so much.
The only thing I'll add there is that with the strengths and the opportunities, I believe that we are exactly where we should be with this work. It was a strategic decision to be where we are with our quality improvement work, to create the plans, to make the training plan, to have everything in place. And then go to implementation. Same with the strategic plan. We really look forward to working with our partners to have a strategic plan. But we focused on having a really strong accreditation submission, and we do. So really looking forward to the next steps and jumping into those opportunities.
It's definitely an interesting process being interviewed because I've never been referred to as a governing entity before. I was like, me? Okay. Other comments or questions?
No, just more good news. This is more fun talking about than the floodplain. Just saying.
Celebrate that one another day.
And well, I think it's nice on the site visit that it wasn't just perfunctory and here's a checklist, and actually sounds like giving you information how to do a better job. And then all the work that it takes to show people around and answer questions makes that more worthwhile. And that's nice to hear that somebody people doing a site visit care about public health and how to, those folks maybe get around more and see different examples of best practices, and sounds like they share their knowledge. So that's encouraging. And yeah, congratulations on, sounds like a good visit. Somehow my mind was wandering back to COVID and the role of the health department. And I think only two of you were there during COVID, and just how important it is to have a well-functioning health department. Obviously every day, but when something huge like that comes up and challenges all of us, it's reassuring to have good people in place that can respond to whatever life throws at us. So appreciate the update and basically good news, and we'll wait and see which of the 3 scores we get. But in some ways, when it says accreditation first, then that's nice that there wasn't a 4th option of something bad. So appreciate all your efforts and coming back to us with good news.
Anything else on this agenda topic?
Just want to say thanks for prepping me ahead of time, and sorry I showed up late, and I'm glad that it worked out. This is
We
good.
did get double booked. That was a challenge.
Well, my laptop was not connecting to the internet about because this was while we were at the thing in Lebanon. And all 3 of my devices were not connecting. And so I showed up 5 minutes late because I was trying to get anything to connect,
It's okay.
but it worked.
It was okay. It allowed everybody to take a deep breath and just be there for a moment. Yeah.
Very good. All right, well, let's move on with our COVID-19 update.
Okay. I will be talking about the COVID-19 vaccine and where we're at, but Commissioner Malone, you mentioned infrastructure and how important it is to have a strong local public health infrastructure. It's also important to have a strong state and federal public health infrastructure. And at the moment, with the current administration, I know, I was like, oh, what got released today? Well, so we've seen some weakening and dismantling of the federal public health infrastructure. So our current federal administration has made changes that include the CDC's Advisory Committee on Immunization Practices. We call it ACIP for short, so you might hear me refer to that. This, along with some of the other changes at the CDC, have left public health leaders feeling concerned. ACIP is responsible for reviewing science and research to inform the votes on critical recommendations that guide our national vaccine policy and insurance coverage each year. So this is the committee that reviews all the data, the science, epidemiology, and makes the recommendation for the vaccine schedule for the upcoming year. So this is who, when, and what gets the vaccine, and then insurance providers cover the vaccines that are on that schedule. So so the process has sort of been thrown up in the air just a little bit, to say it very nicely. In June, our Health and Human Services Secretary removed 17 members from the ACIP and replaced with new members. Some who have been known to show some anti-vaccine views or skepticism of mainstream immunization policy. In late August, the FDA narrowed the populations approved to receive updated COVID-19 vaccines. At the same time, the CDC removed the COVID-19 vaccines from the list of vaccines recommended for healthy kids and pregnant people. Even though ACIP had not yet met to issue their own recommendations. So this was sort of out of order, didn't really follow through. So amid the conflicting messages from the federal government, healthcare providers and pharmacies were reluctant to stock updated COVID-19 vaccines. And many pharmacies either required a prescription or an attestation of underlying medical conditions for the vaccine. This was just a few weeks ago. And the delays left people feeling extremely confused about where they could get the vaccine and how they could get the vaccine. All during a normal time where you would get your seasonal respiratory vaccines. So in response to this, the governors in Oregon, Washington, and California formed the West Coast Health Alliance. This is to act as a unified regional response to concerns regarding the CDC's credibility at the moment and their scientific integrity. Hawaii has since joined. And so now it includes the 4 states. Through this partnership, the states are coordinating health guidance by aligning immunization recommendations informed by data, science, and respected national medical organizations. The hope is that this will allow individuals to receive consistent evidence-based recommendations that they can rely on, and regardless of how federal actions shift. While we were awaiting the West Coast Health Alliance response, several national medical organizations issued their own expanded recommendations for respiratory virus vaccines. This includes the American Academy of Pediatrics. They released their recommendations for children. ACOG, which is the American College of Obstetricians and Gynecologists, released their recommendations for pregnant individuals. And the American Academy of Family Physicians released recommendations for adults under 65. And this aligned with the previous recommendations of past schedules and recommendations. On September 17th, after reviewing the epidemiology, vaccine effectiveness, safety data, and the National Medical Organization recommendations, the West Coast Health Alliance arrived at a consensus recommendation for or recommendations for COVID-19, flu, and RSV. Immunizations for the 25-26 respiratory virus season. For the updated COVID-19 vaccines, they are now available to anyone 6 months of age or older who wants a vaccine. And this is in an alignment again with what we saw in past respiratory seasons. Same with influenza. The recommendations are unchanged from last year. So anyone who is 6 months age or older who wants one can get one. And then the RSV vaccine is also in alignment with the current recommendations that ACIP has recommended. They provided a very nice fact sheet and recommendation guidance for communities and for health departments. So what does this mean for Oregon? As I mentioned, the updated COVID-19 vaccine is available for everyone 6 months or older without a prescription. Individuals can access it at pharmacies or through their provider. Just note that pharmacies vaccinate 7 and older. So for younger children, they may need to see their provider. And then Medicaid and Medicare and most commercial insurance will continue to cover the cost of the COVID-19 vaccines in Oregon. This is effective September 17th. COVID-19 vaccines are still unavailable through the 317 program due to the high cost of the vaccine. This is the program that covers vaccines for uninsured individuals. So at this point in time, uninsured individuals would need to pay out of pocket, which can be a huge barrier. Benton County Health Services still does not have COVID-19 vaccines. Our immunization program pre-booked the vaccines last week. And so as soon as CDC allocates the vaccines, OHA will distribute them to us. So we were kind of in the queue to receive the vaccines. When I say Benton County Health Services, I mean the CHC and our public health side of the house. These are the resources that I mentioned that we've been sharing with the community. The days right after the West Coast Health Alliance released their recommendations, the ACIP met on the 18th and 19th. They met to discuss COVID-19, the hepatitis B vaccine, and the MMR, which is measles, mumps, rubella, varicella, which also is commonly referred to as chickenpox. They voted to recommend the COVID-19 vaccine through shared clinical decision-making, which means individuals would need to consult with our doctor. That doesn't apply to Oregon. But this does allow for the vaccine to be provided for the Vaccines for Children program, which ensures that children have access to vaccines and that it will be covered by Medicaid, Medicare, et cetera. This is good news for the rest of the country. The committee tabled recommendations for the Hep B birth dose vaccine. They were considering postponing it to 4 years, and then they got to 30 days for infants not to be considered high risk. I view this as a win that the discussion and the vote was tabled because hepatitis B is a virus that attacks the liver and causes lifelong infection. Babies are especially vulnerable. 9 in 10 infants who catch the virus become chronically infected. Compared to 1 in 10 adults. The universal birth dose recommendation was put in place in like 1991 to prevent maternal to child transmission. Prior to 1991, having that universal dose recommendation in place, there were about 18,000 cases of hepatitis B among children under 10. Since the universal birth dose recommendation has been in place, there's about 20 cases per year in the country. And so this has been a huge success. Pregnant people are recommended to be screened during pregnancy, but we know that doesn't catch everybody. Access to prenatal care, access to treatment, et cetera, are some of the barriers. And so and that being said, parents also have the option to postpone that vaccine until their first visit with the provider. So it's an option to get the first dose, but it is considered universal. The other vaccine that was being considered was the MMRV. The previous schedule provided an option to parents to either have the combined MMRV as the first dose at 12 to 15 months for their child, or a separate dose. So that would be an MMR and varicella, with the recommendation being the separate vaccine. The committee actually voted to remove the combined vaccine as an option for the child's first dose, which means that will no longer be provided by the federal Vaccines for Children program or covered by Medicaid, Medicare, et cetera. And so there was no new data that was reviewed. The reason why they wanted to see that separated was because with the separate dose, about 1 in 3,000 children may experience a febrile seizure after the first dose of the separate vaccine. There's a slightly higher risk, about 1 extra febrile seizure for every 2,300 to 600 children vaccinated with the combined dose. And then that risk disappears by the second dose at 4 to 6 years of age.
Less than 1%.
It is, yes, so let me say that in a different way. So for the separate vaccine, it's 0.03% of children may experience a febrile seizure. For the combined dose, it is 0.04% of children. So it really is, and parents have the option to choose. That's the way it was previously. And this is far lower than the baseline risk of febrile seizures at 2 to 5% from viral infections. So the vaccines actually help prevent those infections and reduce that risk of fever. So the West Coast Health Alliance issued a response to that ACIP meeting and affirmed the pre-existing American Academy of Pediatrics recommendations that parents have the options to choose whether their child receives the combined or the separate dose at that 12 to 15 month, first dose mark. Always going to be more to come. So the reason why I wanted to show you that kind of larger picture is that West Coast Health Alliance is really establishing itself as that, I don't know if the right word is regulatory body, but it's going to be that body that will review and provide recommendations for vaccines as we move forward. And then we'll work with insurance providers to ensure the recommendations are covered. Anything to add?
Just one thing. I want to appreciate in this meeting the work of Sarah and our communications team and many others who have contributed to the many changing pieces and addressing the concerns. So we had to send out a notice, a memo to providers in the provider community to say, like, we know this is confusing. Here are the guidelines in which based on what we know right now. So I think it was, and there were community messages, there may have been social messages and partner messages, internal staff messages that we sent out as we went along and until we got more information. And that is going to continue until we have the vaccines in our department spaces, when we can then communicate to patients and others that we haven't. But it was a demonstration of some of the skills that we learned during the pandemic, certainly how to quickly come up with a message, how not to overstate what we do know or what we don't know, and to follow up with additional communication in a timely way. So there was a lot of impromptu work group sessions to get that communication right and to be a couple steps ahead with the drafts that may or may not need to be sent the next day.
Mhm.
So, great work.
Somebody mentioned the word confusion. That kind of sums up what we're dealing with here. And it's in normal times, whatever that is, it's confusing. I mean, there's a lot going on and when should I do something or shouldn't, and to just throw out what we've learned, sometimes at great expense, in terms of dollars and people's lives, is well, somehow I was thinking of in 2020, the pandemic was just getting going, and one good thing that President Trump did was Operation Warp Speed and push to get the COVID vaccine moving faster. And that actually worked. In a year and something, we had a vaccine. And, in very stressful, confusing times, got a solution, and then for several years that was routine, and now we're back to, well, you know, it is what do they call that in tennis? Unforced error. I mean, we had the information, getting, you know, fine tuning that, and to throw that out. I appreciate hearing about the West Coast Health Alliance, and wondering, there's something comparable in New England.
Yes.
Do those folks talk to each other? My concern is trying to sort out the best information and do what we can to get that out. And then you had several examples of physician groups that are all also weighing in. And I would hope that out of that soup that there is consistent information that we can try to get out to the general public. Is that in the works? Is that just, how is this, these various scientists that are trying to fill in for what normally would be the federal government's role?
Sure. I can say that, you know, I don't have the details to speak to the specific cross collaborations happening, but you see a lot of consistency across the professional organizations and the two bodies right now that we have making these independent recommendations, and that's because they're science-based. I can't imagine a scientific world or a body such as the West Coast Health Alliance not connecting with professional organizations and colleagues who are doing the same work with the New England Health Alliance.
I do think they're communicating with other states. Absolutely. Yeah.
And part of the problem is tomorrow, it's October, and this information should have been out a month ago, 6 weeks ago, on here's what, if you're following best practices, here's what you should be doing. And now we have this chaos going on.
Yeah, I think the silver lining makes that flu season seems to be dragging later and later, so maybe some folks will be covered a little bit longer as people are kind of a little bit later to but the recommendation is still to start vaccine administration in early September.
And earlier this year, I think we had a good example, was measles in Texas, and, oh, this is something, when I grew up, measles was, yeah, everybody got measles in grade school. And then got a vaccine and almost, we declare we're
We did, and
free of measles.
I think it was like in 2000 that measles was eradicated, and currently we have the highest cases of measles nationally than we have in 30 years. So that it is for concerning when we have confusion and sort of mistrust of the recommendations that are in place. So that's a part of the issue with the MMR vaccine discussion, is that although folks can get that separate vaccine as the first dose, there are most likely going to be gaps in coverage throughout the country because of needing to ensure that we have the separate option in stock. When I say we, I mean pharmacies, medical providers, to provide the first dose.
New parents don't need more confusion and options, and you should do this, don't do that. That's especially on the first child, and there's a lot of learning going on, and the fewer things you have to decide, the better. And so when we have something pretty well settled, and then now you decide and take your time, and it's let's see, unconscionable. There's a word you don't hear too often, but for whatever reason, to throw out what we have learned.
So to that point, you may have noticed on a board meeting next week that that public health will be back for the board meeting. This is going to be, please correct me if I'm wrong, Sarah, more of a seasonal awareness of now is to go and seek these vaccines, and here are some practices to help prevent transmission and to stay well. So we do want to reinforce that public message and to be a voice, a reminder of what's out there and how to access it. Just wanted to add to one thing that you were saying, Commissioner, the impact of delays and confusion. You know, we are seeing a low run of COVID right now in our communities, and thankfully we've had a couple of years of having vaccination on board and getting some natural immunity through infection happening. So the impacts to most people, many people right now who are getting infected looks different. It looks like a loss in productivity. It looks like days called in sick. It looks like feeling miserable, which nobody wants. And you know, those folks who are at higher risk, the more that we have transmission, the more likelihood we have of someone who is perhaps going to have a more severe case and can get hospitalized. So I'm grateful for the work that's come before, and looking forward to sharing some information on how we can continue to keep each other safe.
As far as the new COVID-19 variants, are there different symptoms, or what is that looking like? Or has anyone heard yet? I asked because there's rumors going through the schools and both of my kids have excitedly told me that the new variant makes you feel like you have glass in your throat.
Yeah.
I don't know if that's true.
That is how my 9-year-old described it. I mean, honestly,
Severe,
the doctor.
yeah,
he said
sore
it-
throat.
Anecdotally, that's,
Yeah.
we've been hearing a lot of
Sore
severe
throat.
sore throat, but it's, yeah.
Just speaking from my own experience, the Omicron, same
Okay,
sore throat is sore throat. Yeah.
okay. Thank you. Other comments or questions?
Maybe this will come out next week, but you mentioned RSV, and I haven't heard much about that. Am I remembering this correctly? It's a one-time vaccination.
That's right. Yes. And RSV levels are low right now. And Gerald will provide you with a full update next week.
Great.
Yeah.
And just appreciate your steady efforts and all. It's like going down the freeway and there's car crashes over here and behind you. Just doing your job and moving ahead.
Thank you.
Great. Well, if we are ready to move along, then we will move to Lacey and the federal update.
The news changes every day, so what those put on here yesterday is probably, things are different than today, and actually do have some real-time data that, as we kind of talked, we'll do a couple of little quick moments to talk about Oregon really quick. We'll fast forward through our slides about vaccines. So thank you guys for that very thorough presentation on ACIP and the vaccine recommendations. But we are kind of getting some real-time data right now. OHA is doing their federal response webinar right now. And so I have staff that are sending me some things that maybe you guys would like to know. But you can also save that for another day, but just information is coming at us all the time, for sure, right now. Okay. The Oregon flag right there.
Oh, yeah.
So something that we really just wanted to bring and highlight to you all to talk about is how, as a point of advocacy and something that we're working on right now with the Oregon Primary Care Association. So OHA is exploring strategies to increase CCO managed care rates because right now it's pretty underfunded. They budgeted for 3.4% rate increase this year, but the need is substantially higher than 3.4% in order to meet the cost of care for the CCOs. So OHA has proposed a statewide CCO rate increase of 10.2%. And this would be done by cutting otherwise budgeted funds for the quality incentive program to backfill their budget. This is a big deal for health centers like ours because we receive about $2.5 million a year in quality incentive payments. So that would be going straight from our pockets to the folks who are actually doing the work and into the pockets of the CCO for them to decide how they're going to spend those dollars. So we don't like this at all. OPCA has sent out a survey to health centers to respond to, and then they're going to be meeting with OHA, hoping to at the least bit that we would be held harmless, because we're also, for those of us that participate in the APCM, alternative payment methodology programs, like we, this has the potential to cause us upside down risk and we could wind up owing money, which doesn't make a lot of sense. So again, kind of going back to this idea of unpaid mandates, and what does that mean exactly? And ironically, this is something that we're dealing with on a state level with the quality incentive program, but we also deal with this kind of thing on the federal level where we have a bunch of quality, clinical quality indicators that we have to meet particular thresholds on. And if we don't meet them, then, over the course of time, our funding goes away. So what happens when those start to change, like because of administration priorities and things of that nature? But I will definitely, if there's opportunity for public comment about this strategy, we'll be sharing that with you all, so you can share that on our behalf. And or further conversation, we're kind of in a unique situation in our tri-county area with Samaritan Health Services and IHN, and which is quite a bit different than the rest of the CCOs. So how those funds do wind up getting used versus, and the work that we do. And we've been told year over year for the last 5 or 6 years that we carry IHN's quality metric program, and that through the behavioral health department and the CHCs, we outperform almost everyone else in the system. So the CCO themselves have benefited from our clinical performance. So just putting that out there in terms of conversations. So we won't, sorry, yeah, go ahead.
What is upside down risk?
So essentially, like, we agree that we're gonna at least meet the threshold or exceed it. And then we say, so historically, we've said, okay, we're going to challenge ourselves we're going to increase our performance by 2%. And as long as we meet that, then we get an increased payment of X amount. If we don't meet it, then we could wind up owing like a certain percentage back.
There's a value-based care rubric. And so it kind of goes from just like an agreement to try to an agreement to be incentivized. And there's 4 levels and multiple partial things. It's called the LAN framework, if you're ever interested. We could talk more about it later. But it's definitely like the CCO model is built on some of these concepts, really benefiting multiple partners. And this is a little bit of a huge crack in the intent, right?
And when was this decision made?
It hasn't been made yet. This is a proposal.
Okay, when was the proposal published?
On Friday of last week.
Okay, because I met with Bruce Butler, the CEO of IHN, like on Tuesday of last week, and this didn't come up. So that's okay.
Well, the next time you talk to him, ask him about it.
Okay, yes.
There is an RPC, the Regional Planning Commission meeting this week.
Oh,
so
yeah, that's
maybe
tomorrow.
that's,
Yeah.
maybe this will come up and we'll have more information then too.
Okay, thank you.
We won't talk about the vaccine things, but I do, just as a quick update for you all around, if you're interested, around a couple of things that are kind of emerging right now with within Oregon. So you all might have recalled, we've talked at various points in time about the demand for data from states' Medicaid agencies. There was a data sharing agreement that was put into place between Homeland Security and ICE and all federal agencies were going to agree to share data. Oregon filed a lawsuit along with several other states. And then there was a demand to share information that had to be met by July the 1st, but then it was extended because of the lawsuit. But on September 9th, OHA did have to release data for it. They're saying a small group of members who use the emergency Medicaid services during the window of April to June 2025. So the emergency Medicaid services is federal dollars that can be spent in emergency situations. So what did it used to be called? CAWAM or what here in Oregon, but and emergency departments for folks who wouldn't have otherwise qualified for OHP or other things based off of immigration status. So those dollars are available in every state across the country. So Oregon was very meticulous about what they shared, which was really helpful, because some states have just blanketedly said, here's all the data, take all of it, you filter through it and do what you want to do with it. So there is some information that has been shared. Currently, there's a preliminary injunction in place around the USDA's demand that data be turned over for SNAP recipients. And so Oregon did file that lawsuit at the end of July, and that temporary injunction, the court blocked the USDA's demand for that data on September the 19th. And then I think the only other things just to think about in terms of the shutdown potential, which isn't on another slide, but how that could impact Oregon. So Dr. Hoffy, who is the Health and Human Services, OHA, yeah. Yep, she's in charge over there. She shared that they will continue all services through the month of October, regardless of how long the shutdown continues. If it goes further than that, then they'll assess further down later in the month what they can sustain, specifically in regards to WIC services, which is federal dollars. The service most likely to be impacted, and if a shutdown continues beyond October, is WIC, but they'll reassess that the last week of October. So just some information there. And then the SNAP Ed funding ends today. So if you're familiar with that program through OSU Extension, that is all expiring. That funding was canceled. So it's a pretty big impact to both staff at OSU and communities because they do a lot of work. So. Okay, so there's a new HHS grants policy statement that goes into effect tomorrow. Very exciting stuff, guys. There was a webinar yesterday I got to sit on, and I just can say listening to lawyers talk about things that make them nervous is really nerve-wracking. But it was an interesting presentation, something we're all kind of prepared for, but they did publish a new, possibly final version. We don't know because there's been 7 or so versions. No, sorry, there's only been 5. There's 5. There was one more than one. So there's been 2 since August of the HHS grants policy, which we've talked to you about at various points of times, but the new one was just published and it goes into effect October the 1st. Kind of just for people to know, the pre-October 2024 it went into place in 2013. So from 2013 to 2024, there were no changes. October 1st, they announced that they were moving to Part 200, which we'll talk about here in a second, in October 2025, and then they have now added a bunch of new rules. So instead of just the 8 provisions that were originally written in Part 200, they've added 4 more. So what basically, sorry, yeah, go ahead.
Did you choose the title New World Order?
No, they did. This is from Feldsman.
Okay,
So when
I'm
they
like,
talk
that's
about
concerning.
yeah,
Okay,
I'm not gonna lie.
but that's not a federal
When-
thing, that's whoever.
From an attorney.
Okay,
Yeah,
great.
this is down there, copyrights, all reserved stuff. So essentially, the old one was in place for 17 years. There were multiple different versions, which we talked about with you all, and Christine and I were the ones that discovered the difference between the July 24th and the April 16th. So we appreciated all the national shout outs we got.
Yes.
That was really nice. And then with no announcement again, they put another one out on October the 10th, but they wanted us also to remember, which was great because we're not lawyers. So this is the order of procedure, right? So the US Constitution comes first, and then, yeah, it's supposed to, right? And then program authorizations and appropriations and any of the laws, that are written in there for us, that comes second. And then the regulations, so then this is then the HHS grants management comes third. And then after that is executive orders after that. So I guess they can just keep updating the regulations to match the executive orders, but we'll see. We'll see how many of them are out there, but. I just want to go back. Oh, no, it's right here. I think it was, sorry. I may have gotten a little. Yes, okay. It's not on here, but just the important thing that's in in this new version of the grants is that there is the ability for them to cancel grants if they do not meet the priorities of the agency. And the agency's priorities are determined by the executive branch. So those are some things to keep in mind. We'll talk a little bit about HRSA has updated their strategic priorities. We'll do that in a second, but also in this new grants management guide has some very specific things around Title IX and whether complying with the order to not promote gender ideology. And we're still trying to determine who meets the requirements of Title IX or not, because we've heard multiple interpretations that it's any approved curriculum that produces a certificate. And so we have the Community Health Worker Training Hub that has an approved curriculum through OHA that does produce certificate and licensing. And so we're trying to determine whether or not OHA would consider that program a Title IX program or not, or if it's not considered, if we aren't directing any federal funds to it. But we'll talk a little bit more about federal funds in another slide here and what the feds are considering federal funds and what we consider them. So the risks continue and we are just continuing to listen and attend every opportunity we have to learn more and paying attention to all the bulletins that we're getting. So this was the word that kept being said over and over again is just keep in mind everything can be canceled on a grant by grant basis. So why do we say, yes, we did a fantastic job, we're doing great work, but Debbie, there were other changes. Sorry, Debbie Sessions also sat in on the call yesterday with Feltzman, and just going over there are quite a few things around budget changes and where you're using your federal dollars, making sure that they are what you proposed. And so just making sure that we are doing exactly what we're supposed to be doing. So we feel good about where we are right now, but we want to stay there. So we do, Tom Ingalls, you all may recall or don't recall. Tom Ingalls is the director for HRSA, and he's going to be at the Region 18 Fall Primary Conference, which Christine and I are going to be at holding a session. So we've been invited to a conversation with Tom Ingalls to kind of ask more questions. And again, Christine was at an NWRPCA event last week or the week before last. And they said, what do you guys want to talk to them about? And Christine said, how to support public entities, please. This is something that we don't feel like we get enough support on because it's complicated whenever local government is providing care, and how do we meet all of those requirements while still meeting our state and local statutes as well. So
can you remind me what QIF-TJI means?
yes, that is the Quality Improvement Fund for transitions. Go ahead.
Transitions and justice involved populations. It's our jail grant. So it's that justice involved integration effort, which is just formally that QIF-TJI. Is
connecting individuals to primary care upon reentry into the community.
Gotcha.
Yeah.
Okay.
We got that before you came on board with us.
Yeah, that's a lot of letters.
Yeah. It is, yeah.
How they roll.
And so now that brings us to today, where we're at a pretty high risk of a shutdown, possibly. At a minimum, folks are preparing for it to last about 2 weeks. HRSA, or is it just Bureau of Primary Care, has said that they'll lay off 47%?
42% they'll furlough.
42% of their staff. They did issue a bulletin yesterday that said that they're hoping that the payment management system would continue distributing funds. So we, after today or this afternoon, we'll work on a drawdown for our funds. Yesterday, Jim McCray also had, and he's the head of the Bureau of Primary Healthcare, making sure that they'll make sure that they have enough staff to do the mandatory things. So they're hoping that it won't have any direct impacts as long as it doesn't last through mid-November. So that's what we're hoping for. Just a quick update on the Rural Health Transformation Program. You all forwarded the call for information from OHA to all of us to kind of provide some information. I was able to provide some comment on that. The applications opened on September the 15th. States get to apply. And they did on the 15th release what their strategic goals were for the program. And then they also, in the webinar about the application process, talked about what the funding could be used for. So transformation of care delivery, which is another just word for like innovation and technology, improved access to quality of and cost of healthcare, expanded or enhanced services, but not to duplicate programs. So you can't use this for like offsetting operational costs. And then working on technology infrastructure programs. So, and again, you can use it for construction, clinical services that you can bill for, or for a bunch of the other things that are outlined in the notice of award, which is just like everything else. So OHA has not released what they put their proposal in as yet. So once we know, we'll let you know, and hopefully we'll be able to apply for some of those funds for our rural communities here in the county. So this is HRSA's new strategic direction, which they published on the 12th of this month. They're reaffirming their mission, but kind of have tweaked the words a little bit in terms of thinking about improving health outcomes for underserved Americans. But they're really looking at accountability and measurable results, and then that there will be fiscal impacts if they're not met. So this is kind of new words, new language.
Sounds like a threat.
Feels a little bit like a threat, which is kind of the words kind of that we get at most of these updates with the Bureau. As kindly as possible. We do love our support staff at the Bureau of Primary Healthcare, but certainly the language has shifted a little bit from reporting activities to having to show outcomes, prove outcomes. So,
and I would add that even though we've seen that Make America Healthy Again framework, it continues to be developed in the back end and with very specific groups that don't necessarily connect to what we're doing, but this is now very firmly anchored in some strategic direction for the federal agency, which is, like Lacey said, that fallout, that hierarchy. And so we don't, I think, know what that means yet, but they are very clearly referencing and now using both approaches and documents kind of to support one another. And that will be new for us because the MAHA space, or Make America Healthy Again, is very new and developing and controversial, I think, in a lot of ways, or misunderstood. And so how we will be held to some of those goals and standards is yet to be seen. That feels a little threatening now.
So they're listed here. These are their new kind of priority areas and kind of the implications to the programs that we work with. And so, how we interpret them is again, like one of those great things, like with the compliance manual, they give us a lot of rules and ideas of how you can implement them. But then at the end of the day, it's all subjective because they get to decide whether or not you're meeting them in terms of the program things. Grants management is a little bit different there. It's not very subjective, it's very objective. And so that's kind of the difference between the two there. But when we were told by the Bureau of Primary Healthcare representative that was with us that they are expecting to have a new compliance manual and a new scope of services manual to come out from HRSA sometime this fall or in the winter. And so just really telling all of us that when that comes out, you're not good for, like the old compliance manual that we just met all the standards of. You have to just be continually adjusting and making sure you're doing that in real time, because as it gets published, you're held accountable to it. So we expect that a lot of this will be outlined as those documents come out this fall.
Remember from a previous presentation that you have a kind of national network, and I assume you're talking to one another, and what does this mean, and
yes,
what's the magic word that we're supposed to use on this line?
Yeah, and also like in terms of continuous quality improvement, like what was recommended initially, there was for certain things, they said, hey, just write when you draw down funds that you're meeting the guidelines and the Public Health Services Act, Section 330, which is our grant, like you're just doing that. And then we got feedback that was not sufficient. And so they told all of us change again. There's constant flow of information. People are sharing things. So we are very fortunate to be in a network that really cares about making sure we're all successful and that we're not seeing this as competition, but rather we all need to be successful in this endeavor of providing primary care to the most underserved people in the nation. So, so Medicare, in terms of thinking about service delivery CMS, the comment period has closed for, there's a new set of payment policies or the provider payment policy. So there's a lot of feedback going on around that because around capping fees and kind of just a new approach to care, which impacts a lot of other places, not FQHCs, because we have a rate that's determined through our PPS and other things. But they have said that they're going to extend the telehealth flexibilities for FQHCs and rural health clinics through December 31st. Barring that this does have to pass through Congress. So there may be a temporary window where this, so we're just telling folks, hey, let's not do telehealth for a little while until Congress gets back into session. But this is the recommendation that CMS is proposing. So we agree with this proposal. This is important. Again, somehow we got kind of left out a little bit. Primary care got left out. Behavioral health, telehealth flexibilities are written into law now. So you can have telehealth visits for behavioral health services as long as you have one in-person visit a year. You all recall, we've talked about the PERORA, Personal Responsibility and Work Opportunity Reconciliation Act. This has to do, we now know how to say it, PERORA. I think we spent 3 weeks deciding which of those vowel sounds go first. Essentially, this is saying that a lot of programs, most programs under Health and Human Services fall under federal public benefit. This was what happened in the end of July. The Community Health Center program was included in that. And a along with a lot of others, including the community mental health program, most of the block grants through for substance use and treatment, most all of them. And then Oregon joined the 20 states and filed a lawsuit. That lawsuit was heard in court. A nationwide injunction was in place. The lawsuit was heard on September the 10th. And they did issue a temporary injunction, but until it continues through the courts, but it only applies to the 20 states who filed. So on September 11th, the other 30 states were no longer covered by the injunction. And so they had to begin to comply with the new updated language from Health and Human Services. And so what we heard last Monday, so we could go Monday, was during the week of 15th, things are going out. As is the revenue cycle, the billing cycle for healthcare services. And so this network of folks, right? Experience that everybody is doing. We are getting more reports that they have been getting rejection. So a new law present. And while this is kind of, obviously it's concerning, but what makes it a little bit more concerning is that what we is the federal dollars that each center gets to decide by those, of them apply them to general operations through salaries for medical providers. Is it the fee scale, so that's the federal benefit, or are they saying all program income? And so the reason why this is concerning is that this would appear that they're talking about all services under the community health center program, because if a Medicare claim went through, that means it was just a primary care service and not subject to the sliding fee scale or anything like that. So certainly we're hoping for some more direction. This is one thing that we will ask Tom Ingalls specifically, this is on my list of questions, is how they expect health centers to implement this. And then of course, we'll continue to ride on the coattails of Dan Rayfield. We appreciate all of the work he's been doing to help us at least be prepared before these things start to come into place.
And to connect a dot, that CMS ability to identify who's lawfully present is also connected to sharing of data.
Yeah.
So that's why these data sharing, either intentions, leaks, or now compulsion to comply really matters, because if CMS doesn't know, how can they know? But once they know, this is kind of one of those things that may happen.
Okay, so we have a few updates here on pharmacy, just some things. You guys got to hear me talk about this a little bit, so I apologize. We met with Representative Fink, who came to the health center, but I want to make those that this rebate program with public on, we haven't heard yet how this is going to be applied, but essentially there was a program that is going to be implemented that would require 10 drugs starting on January the 1st for us to purchase drugs at the WAC price, which is the wholesale acquisition cost. Yeah, here we go. See.
They said it at the site visit.
Yes,
Yeah.
We got it. Yeah. And we have to purchase those drugs at cost, whereas right now we purchase them at the 340B cost. And then we would submit, after we utilize the stock, then we would submit it back to the manufacturer for reimbursement through rebate. The drugs that are on the list treat these different conditions here: diabetes, heart failure, chronic kidney disease, rheumatoid arthritis, psoriasis, arthritis, a bunch of things here. How that will impact our 340B pharmacy. We do not purchase any drugs outside of the 340B program. We do not keep any commercial stock, but it will increase our monthly credit to about $200,000 a month in terms of the drugs that we currently purchase. This is just like an example drug, Enbrel, which is an injection for rheumatoid arthritis. We currently purchase it at a penny a unit through the 340B program. And then this would be, $2,000 a unit. Yeah.
And it's missing $2 million per year.
Yeah,
We
I
had
mean that-
some version challenges this morning, so it's
Okay.
200,000
Like, well, the math will tell you.
and
it's
2
around
million a year.
Okay, so, sorry. Yeah.
$1,002.
Yeah.
Yeah.
PowerPoint weren't playing
So
nicely
there's a
this
lot
morning.
of things, yes, it's big shift, big impact, cash flow issues, huge potential cash flow issues. And for health centers, so the public comment period, what we've been advocating for, what the National Association of Health Centers has been advocating for, is to have health centers be excluded from the rebate model. There was a really kind of scathing article that came out on Sunday about the 340B program and how hospitals have been profiting from it. While I'm happy to send that to you guys if you want to read it, but while the reporting, is fairly true, in terms of how many hospitals do benefit from 340B discounts. It doesn't mention anything in there about the community health centers or how we utilize it. So that's concerning.
Where'd that come out in?
I think it was the Washington Post.
Or Wall Street Journal.
Well, yeah, one of
Wall
those
Street
two.
Journal.
Yeah, I can send it to you.
But the CHC model is to reinvest it. And so there's a lot of services we pay for that aren't covered in that alternative payment or value-based care model that are possible because of pharmacy and 340B. And so if that's not what hospitals are doing, and that's what community health centers are doing, people have long argued you need to distinguish that this is like profit driven and this is investment focused, right? And the program's all the same.
No, the journalist.
Yeah, there we go. Yeah, that's a great idea. Great idea.
Now we got it.
There was also, which we mentioned to you guys the other day, that there was House Bill 2385 was passed in the last session here in Oregon around contract pharmacy. Just saying that a lot of pharmacies back in 2019, 2000 started to say we will only use one, we'll only allow a covered entity, which is a health center, a hospital, rural health clinic, to claim one particular pharmacy for our drugs. So if you're Eli Lilly and you say Safeway is where we have most of our patients are filling those drugs at, so that's where we can get any of the Lilly drugs. And then, another manufacturer picks a different one. We're saying it impacts patient choice. And so Oregon, along with several other states, have passed laws about this, but now the manufacturers are suing. And there seems to be quite a bit of support for big business in terms of how these lawsuits are going. So we have provided testimony to OPCA, and OPCA is working with the state legislatures on this. So just keeping you up to date on what we find out. We'll skip the ASIP update there. Oh, and that's the end. Okay, there's a lot of other things, but we decided what's happening in Oregon today is not our business entirely right now, so.
It could change tomorrow.
It could change, so. Any questions for us?
Good luck.
Yeah, thanks. These meetings, comments have changed quite a bit over the course of time. We appreciate it. We need all the luck we can manage here.
Well, again, let us know how we can be supportive, if we can help in any way.
Absolutely. Thank you, guys. All right, so then that takes us to, that was
That's
the
just
slide
an
at
old
the end,
slide.
yeah. Sorry. I guess that takes us to our last agenda item, if you guys are okay with that. So
Yes.
back in August, was it in August? This is just September, so it would have been in August. We met with you all kind of at the beginning of the month and talked about just wanting to make sure that our practices, internal and external, allow us to comply with kind of the ever-changing needs, terms and conditions to our federal grants, both at the health centers and health services, but across the county, because we have them, they live in multiple mini departments. And last week, was it just last week? I believe that you all approved the new updated employee policies, and a lot of the things that are required for our terms and conditions and attesting were included in there. And CIS, read over those as well and approved them and said, yep, they meet the standard for civil rights and all of those anti-discrimination whistleblower laws. And so now we have our next step in this process is this resolution that we wanted to bring forward to you all. I don't know, do we usually read this out loud? Is that how this works? So you guys have read it. Okay, good. Thank goodness. But essentially just the resolution just states that here at Benton County, we are committed to offering open and accessible programs to everyone. And that if people do feel like they are experiencing any discriminatory behavior from the way that services are provided or from staff or people representing the county, that there's a way for them to bring those concerns forward. And that we will address them appropriately. So that is essentially what's in the resolution here.
Yeah, and Commissioners, I might just add, as Lacey stated, the personnel policies did a great job in terms of anti-discrimination rules, regulations that have all been approved. And remember, that was the scope of just our staff. This obviously is intended for all those that we serve to make sure that that message is clear as well. I think we all recognize with the passage of this resolution, there are likely things that we have out there, forms and all form, communications that is going to need to be addressed over time to make it consistent with the rules and regulations. But as opposed to us trying to chase our tail and find out all of those various things, we thought best to bring this resolution. And it's really key to, one of the things to point out is this resolution will supersede any of those policies that might be in conflict out there that we do need to clean up. So I like to say this is first step. Work still needs to continue, but at least what it does is it puts a resolution in place. And as Lacey articulated very well, this is not just about the health center. This is about the entire county and any federal funds that we receive. There could be a situation where another federal auditor comes in and says, hey, somewhere in the county, you're not complying. It could impact every federal dollar that we have. So we want to be safe in this. The other thing I want to point out, and Ann has been working with this as well, as Lacey said, that there needs to be a process in place that if somebody comes into the county and feels that they have been discriminated against, there needs to be a process associated with that. So Ann's going to help us with making sure that the public is aware that this resolution has been put in place. There will be complaints that would go directly to the county administrator to be addressed. So that's again to still be a work in progress. I guess in closing, and Lacey has used some examples that we're already starting to see some situations that come up in relation particularly to the health center, that having this in place and saying, this is our policy and this is our process will be helpful to be able, particularly for Lacey and others to be able to point to. So I could imagine that we'll probably be tested in those situations going forward. So thank you for your consideration on this. I'm sorry.
Questions or motion?
I'm ready to make a motion.
Just a comment, I appreciate the kind of the context that we're trying to operate in and express our values, and I will move to approve the resolution R 2025-024, ensuring open and accessible programs for all in Benton County.
Second.
All those in favor say aye.
All right.
Aye, motion passes unanimously.
Thank you, Commissioner.
Anything else on this agenda item? Okay, anything else for the good of the order? All right, well, with that, I'll adjourn the meeting at 11:29 a.m. 11:25 a.m., sorry.
The missing 4 minutes. What happened to that?
Well, that clock's even slower than. Okay.